Hey, deserving listeners, I thought I would answer some of your emails that you email via the website. And this first email is from an anonymous listener. She says, I am an intern trying to find my own therapeutic approach. I have been trying to model my therapeutic approach after yours. Well, just chiming in, it's very flattering going on. I've pieced together that your approach is psychodynamic based with a focus on lifelong attachment. You also focus on schemas and some object relations. Would you say that describes your approach and theory of change and theory of healing? Also, would you ever write a book after you're done with the grief one, of course? Would you ever write a book about your approach? I think it would be so cool to have a generation of Hondian therapists. Hondian. I've also heard of Hondonian or Hendane. Anyway, anonymous listener says, thanks so much. End of email. Yeah, well, that does describe it pretty well, but I would definitely add the various humanistic theories and therapies definitely to this. I don't, I guess, talk about those enough, or they're so effectively integrated into not only the practice of therapy and the philosophy of therapy, but humanistic theory has integrated the popular culture to talk about self-esteem and self-actualization and to value feelings and to believe that people are mostly good and that if you just help people to realize that themselves, then things tend to go well for them. There's a lot of things I could get into on this. There's caveats and critiques of all the theories when it comes to being a therapist, but definitely humanistic theory, whether it's Rogers or Gestalt or Whitaker or Satir or existential therapies. These are very core to who I am. The other major theory to add to the list is systems theory. I would like to think I talk about systems theory quite often. I will tell you that I didn't understand psychodynamic theory or systems theory until I had been a therapist and a professor teaching these theories for about 15 years. So I taught these theories before I really grasped them. I grasped them enough to be able to teach to students who had no idea what these theories were. But I needed a lot of time and a lot of looking at it from various angles and a lot of experience just working with people and seeing how humans operate. It's one thing to learn a theory. It's another thing to try it on for size when you're actually treating clients and assessing people, and also just looking at your own life, looking at your own families, your own friends. Eventually, these concepts start to come into focus, and it's asking way too much that graduate students would comprehend these things. But like I said, you can comprehend them enough to move forward with mentorship, that sort of thing. But really, all the theories I incorporate often. I might not be explicit about it, but behavioral theory, absolutely. In all of my talk on habituation and exposure and trauma recovery and PTSD work and OCD work and any anxiety work, absolutely is standing on pretty much the only foundation of behavioral theory, behaviorism. Other theories that I absolutely incorporate that you might not detect or something, or might not even know that they are formal theories, are social constructionism, feminism, cultural relativism. Again, there are critiques of these as would be expected because they're complicated, but I absolutely have spent the time to understand these philosophies, read about them, hear about them, absorb them, bump up against all the barriers to comprehending and going along with it, and then eventually, hopefully, cresting the hill and able to get it enough so that it's sort of in my bones. You know, it's one thing to know a theory and to apply it to a situation. It's another thing to just naturally think that way, which is what you want to get to. And again, it might take 15 years as a therapist to achieve that. There's also, of course, cognitive theory. People often talk about CBT, cognitive behavioral therapy, and consider cognitive and behaviorism to be this like related or something. And not really. I mean, there's an integration, a popular integration of cognitive behavior theory, but that would be like saying that integrating attachment theory with systems theory is, automatic or something. No, cognitive theory and behaviorism, cognitivism are very different things. In fact, historically, for many decades, these two camps, these two schools of thoughts hated each other and were really vying for resources and for legitimacy. Eventually it was integrated, and it's fine. But understanding cognitive theory fully without behaviorism muddying the waters is important. Schema therapy kind of emerges out of that, but also psychodynamic. I'm not going to go into it because I could talk literally for years on all these things. And I also, as a therapist, and I guess as a thinker, in terms of the way I see myself and other people, I will incorporate cognitive or collaborative theories, collaborative therapies, or what a lot of the textbooks will quote unquote call postmodern therapies. I'm not a huge fan of that label for a few reasons, but it's fine. And these are your solution focused, your narrative, this kind of stuff. And again, easy to read the paragraph that describes it, but years of fully comprehending and absorbing what these theories and therapies are actually trying to propose. The people who develop these. So cognitive theory is probably fairly easy to get. Behaviorism is pretty easy to get, but and not to say that that's an indication of their usefulness. It's not. It's very powerful, very elegant, very intuitive, and maybe it's just related to the way that we think, at least in my neck of the woods. But when it comes to the collaborative theories or psychodynamic theory or psychoanalysis or object relations or even attachment theory to some extent, systems theory, cultural relativity, these things, social constructionism, these things are mind-warpingly difficult to get, let alone to absorb and to practice. It's really hard. And then, of course, I will incorporate neurobiological research, whether it's understanding of medications or sleep or the differences in the brain functioning of someone with ADHD, or when it comes to trauma recovery and memory and the hippocampus. And so, there are certain models of understanding why things play out the way that they do and inform how to help people, how to frame things for people. And there's models of understanding how the brain operates. So I will incorporate all those things. And some people, particularly in the past, would say that it's impossible to integrate all those things. One, because they are incompatible with each other, which never made sense to me. And two, because it's not humanly possible to get all those things. Well, I've had the privilege and the pleasure of being a professor and a therapist and I've been a professor and a therapist for about almost 30 years. I've been a podcaster for almost 17 years. And a good portion of my job description involves looking into these things and getting paid to do it, or at least it enhances my viability as a therapist or a professor. So I will, for example, do a deep dive on a theory for the podcast, and it helps me as a professor and as a therapist, or vice versa. You know what I mean? So I've been nerding out and spending a lot of time on this, and I'm confident that I do understand these things. And I've had some amazing professors and mentors and people who understand these things, and to do co-therapy with them in the room and watch them say, oh, okay, I kind of get it. I've been to trainings and blah, blah. And, it's just iterative process getting down the road. So there's that. But yeah, I've had arguments, full-on heated arguments with other clinicians, particularly older clinicians, who claim that you cannot integrate systems theory with psychoanalysis or cognitive theory with humanistic theory. And there are some incompatibilities in a sense, especially if you go with the way that it was interpreted by the hardliners, by the purists, so to speak. Because, well, I won't go down that road. But I don't have any problem integrating. And it's been shown by research that for us therapists to be effective, it's important that we tailor the therapy to the client, not tailor the client to the therapy. And if you have one model of understanding how people work and one model of trying to help, then you'll have a tendency to see everything as a nail because all you have is a hammer. Whereas if you understand all of the theories, all the major umbrella theories well enough, you can really be in the client's world and then intuitively or in a thoughtful way, not intuitively, scratch that from the record. You should never, as a therapist, well, there are intuitions, but when it comes to this sort of thing, you should have this concretely understood, and even in the treatment plan anyway, that you would be able to go through you'd be able to see the problem and also know what sort of theories help with that. For example, if someone comes into my office and doesn't really have a clear goal and they've never been to therapy before, there's not any crisis, and they just want to tell their story, and they don't know how to describe what they're going to do in therapy. And so sometimes what I will frame it as in my mind and to them is that it's self-actualization, or it's firmly planted within Rogerian styles of therapy, or maybe Gestalt, that kind of thing. Now, some of you might be, let me go down that road. Whereas if someone comes in saying that they have a good relationship with their partner, but they only have a few sessions and they want to work on, as a couple, they want to work on a particular kind of argument that they get in, maybe around parenting, but mostly they're okay. Well, then solution focus can work pretty well because it does lend itself to more short-term therapy, and there's no long conversations about history and the past and one's childhood. If you have 3 to 5 sessions, which is what a lot of clients actually come in for. I can't remember the average, but the average time that clients will stay in therapy is something along those lines, like 3 to 7 sessions or something like that. So if you are using a model of therapy that investigates people's histories for 5 sessions, you're going to be wasting a lot of time and not getting to the point. So now you can screen people out along those lines, but whereas if someone comes in with a personality disorder, then that's a whole other thing, right? Then we're talking about corrective experiences and cognitive therapy and a bit of narrative and humanistic. You're really probably doing all the things when it comes to personality disorders, just at different phases. You know what I mean? Anyway, has to do with stage of change. Read John Norcross. He's a pioneer in this area. Anyway, so yeah. Oh, the other thing that I wonder about, if people are thinking, well, what about internal family systems or EMDR? Where do these things fit in? And what I'll say to that is those are integrations. Those aren't umbrella therapies. And the developers of those theories, or EFT, emotional focused therapy, these authors who developed those theories never claimed that they are an umbrella foundational area of thought within psychology and psychotherapy. They are pulling from various different therapies and applying it in this particular way, in a way that is effective, but it's not the umbrella. And when you understand the umbrella, like if someone, and I've had supervisees who want to be specialized in cognitive behavioral therapy. Well, what I start with, the fundamentals, is you need to understand cognitive therapy first, and you need to understand behavioral therapy first, and then you can integrate the two. You can't just learn cognitive, or you can learn CBT, I suppose, but you're really missing out on a lot of great stuff. you're missing out, and it muddies the waters, because if you don't understand the principles of behaviorism and the principles of cognitive theory, cognitive therapy, then you're kind of following a script that people gave you, or instead of operating from the fundamentals of humans. And anyway, so internal family systems is an iteration. I mean, some people could say that it's unique and brand new, but I would say, and I think the author would agree, that this is an integration of sorts of what they would say is systems theory, which I don't necessarily agree with, but there's certainly parts work that existed before this. There's also like schemas. Anyway, so that's the answer to that question. Let's move on to another question. All right, we're back from the break. So this next email is a similar theme regarding theoretical orientation. Sarah in Illinois, she says, I am enrolled in a master's in counseling program, and I am struggling with determining my theoretical orientation. Just chiming in. If you're not a clinician, if you're not in graduate school, or you're not at this point in graduate school, it is almost universal, if not universal, that you, as a student, have a number of options to choose from regarding theoretical orientation, and you are required to choose and to spend extra time getting to know that theory or taking a class or something. I believe there are some graduate schools that force you, and it's advertised as such, to learn at least one particular theory. Like in my program, we force, but we advertise it as such, the students to learn systems theory. You don't have the option of saying, I don't want to learn that theory. Like you have, but the other available theories, of which there are many, are up for grabs. You know what I mean? Anyway, so I'm enrolled in a master's of counseling program, and I'm struggling with determining my theoretical orientation. As you mentioned, my theories course only skimmed the surface of the big 8 theories. Just chiming in. Yeah. So I believe that the big 8, I don't know if that's how it was framed for Sarah in Illinois, or if that's what I said, but just to rattle those off, let me make sure I follow my notes here. You have psychodynamic psychoanalysis. That's often one of the 8. Then you have humanistic psychotherapy. Then you have cognitive therapy. Then you have behavioral therapy. Then you have, there's various different names for it, but there's feminism, culture, multiculturalism, diversity, cultural understanding, cultural relativism. Sometimes social constructionism is in there as well. Privilege, power, context. There's a lot of, I grew up in a time when they just called that feminist theory because it, originated from feminists, and it blossomed into not just sexism, but into all forms of oppression and the syndromes of both the privileged and the people who have the agency, and the oppressed and the marginalized and the dehumanized. Anyway, so what am I at 5 right now? Then you have the collaborative postmodern therapies that I've talked about. Often there's a neurobiological chapter in a book as well. And then there is systems theory. Did I mention that? So you got psychodynamic, psychoanalysis, object relations. These are all, there's other things you can put in there, ego psychotherapy, ego psychology. Sometimes Jung is thrown in there as well, or Adler sometimes. Anyway, so you have psychodynamic, you have systems, you have collaborative postmodern, you have neurobiological, you have systems, you have cognitive, you have behavioral, and you have culture feminism. Did I repeat any of those? So for Sarah, she's saying, my theories course only skimmed at the surface. Yeah, because even if you spent the entire term studying just one of those big 8, you still wouldn't really get it. These theories were developed and iterated upon by, geniuses that go back generations. These are not easily understood, and students have to go easy on themselves. I know it sucks to think that you could spend all that money and all that time in graduate school, and what I'm saying is it's not expected that you're going to get any of this stuff. It's an introduction. One could argue that there should be more theory instruction, and sometimes there is. And I'm guessing for Sarah, this was just the introduction class. Usually there's, more deeper courses as you go forward. Anyway, Sarah says, I was profoundly moved by Carl Rogers' focus on empathy and truly understanding one's client. However, I feel that more practical application is needed in later therapy sessions to help clients take action and implement change, such as CBT or reality therapy. Are you aware of any theories that may have a good combination of the two? I have researched independently, but have come up short. End of email. Well, oh boy, you could just do that. You could have Carl Rogers and CBT and maybe reality therapy. Reality therapy has issues, but it can be used well. But if you integrated Rogers' theory, which is complicated, it's often framed as just good listening skills, and it is far from that. Carl Rogers and his philosophy and his research and all the collaborators that he worked with, it is fucking complicated. I mean, phenomenology is a mind screw, and when you get it, it's like whoa. And when you experience it as a therapist or as a client, it's profound. It's very different from just good listening, So there's that. And you could absolutely integrate that with CBT. That would be a good combo, honestly, and fairly easy to comprehend in graduate school because, I just got done saying that but you could understand Carl Rogers enough to use it pretty confidently at your internship or shortly after, and CBT similarly. But what I'll say, again, is that it's my recommendation, and I know this sucks, is that you understand all 8 because we want to tailor the therapy to the client. If a client comes in and they are suffering from something that, in all likelihood, the most effective model of understanding and treating the client is, say, systems theory, and you don't understand systems theory, then you're potentially going to be spinning your wheels. You might even harm the client. So I know that's a lot, but I don't know what to say. It's just what I believe. Now, we can't be all things for all clients. That's ridiculous. But for the general therapist, the typical private practice therapist, we get a lot of different kinds of presenting problems. And it's really hard to screen out certain things because clients don't necessarily know what to describe to you over the phone before screening, Anyway, so there's that. But there's another a word in here that I am not a fan of, Sarah, which is practical application. The way that people talk about CBT is that it's practical. Reality therapy, it's practical. Okay, fine. But you shouldn't be doing something that's practical. You should be doing something that's helpful. And if it's helpful to be practical, great. But there's this criticism that Carl Rogers is not practical or psychodynamic therapy is not practical. They're all practical if applied to the right sort of client in the right situation at the right phase of therapy. All of the therapies are practical. There's no impractical therapy. CBT is not the only fucking practical or evidence. They're all evidence-based. They all have tons and mounds of evidence. CBT, as it's described, and the practitioners and the theorists will often claim this because they're trying to sell a book and they're biased, is that CBT is practical. It's like getting down to brass tacks. It's like helpful. Well, I'm here to tell you that the kind of mindset that these therapists will have is ridiculous. It's like, how can I, now, like I said, CBT is wonderful. I use cognitive therapy all the time. I use behaviorism all the time. In my personal life, with my dogs, I use behaviorism. I use cognitivism in just, in the way that I think about things. But there's a frequent joke in our field, and sometimes it's in a Far Side comic or a stand-up comic or a keynote speaker at a professional conference will say a joke that for us therapists, there's this temptation to just, shake clients and say, stop doing that, right? Or snap out of it, or stop thinking that way, or stop self-sabotaging. If it was that easy, then we wouldn't need to exist. There would just be TikTok videos that would cure everybody. There's a subreddit, I can't remember what it's called. I'm not great with words, given I think my mild dyslexia. That's what I'll blame it on anyway. There's a subreddit that is dedicated to outing, online influencers or people who put stuff out there that claims that if you just follow this advice, it would solve all your problems or a particular problem, like you're suffering from poverty or something. And it's just like, having trouble, meeting ends, having trouble paying your bills, follow these 3 steps. And it might appear like, oh, okay, those are, but if you really think about it, it's like, but I'm still being oppressed by the, owners of property and by the billionaires, and the politicians are not raising minimum wage. So it's like, okay, I guess I can stop paying for Netflix and that'll save me some money. But it's true. But we're talking about having to pay exorbitant rents and stuff. Anyway, you get what I say. And so this way of thinking of like, I need therapy to be practical. And I get it, because when you're a therapist, it can be overwhelming. And the theories, and especially if you're taught it in a certain way, it can feel like, well, what's the end? What's the outcome? How long does this take? And again, it just really depends on the presenting problem. Some presenting problems are 15 years of therapy to get 50% down the road. Some problems in therapy, I've cured or eliminated the symptoms of PTSD in less than 10 sessions with people before. So sometimes it's brief, sometimes it's long. Just depends on the client, depends on where they're at, depends on the severity of the problem. There's a lot of things. So I get the practical urge. So there's that. But the way that these therapists think is that if someone's depressed, for example, and by the way, cognitive theory and behavioral therapy doesn't have anything to do with just getting people to do something. That's the way it's often applied, because there's this urge by humans to just forcibly get people to change, because it's frustrating, right? You have someone that has treatment-resistant or long-standing depression, whether it's moderate or severe, and as a therapist, you just feel like ineffectual, and you worry about the client. There might be suicidal thoughts, and you're trying a lot of things and nothing is working. And many of the things that you've talked about with this client, the client hasn't done. You might have gone over different tips, like as soon as you wake up in the morning, get out of bed, don't doom scroll, stop looking at your phone before you go to bed, stop looking at Twitter or something, eat better, exercise, get outside, and they come into therapy the next week and they haven't done most of it or any of it. And you're thinking, well, if you're not going to change, if you're going to put effort into it, then what's going on? And because the therapist feels like they're failing and they worry about, so they're attacking themselves internally, and that's hard. And so they look for a solution. So they blame the client, and they look for a practical therapy, which CBT apparently appeals to this, but CBT is not. What I mean practical is that you would tell the client, look, you have to do X, Y, and Z. And what's the barrier to that? You might start getting into motivational interviewing and this kind of stuff. And yeah, if that works, if that's helpful, then do it. Or you think it's going to help, then do it. Sometimes clients need that kick in the butt, and that's what they're coming into therapy for. But things are rarely that easy. If they were, the client would do it. People don't like to shoot themselves in the foot. There's other reasons. There's other problems afoot, The phrase that my students and supervisees would learn from me is people come to therapy because they have problems. And that sounds like an obvious statement, but I feel like therapists need to be reminded of that sometimes, because as therapists we'll run into the client will say, I need help with depression. And then you keep bumping up against a barrier, resistance or something. And my supervisees and me at times as well will just be frustrated of just like, how come this one thing is if I could just get this like tendency or this psychological personality trait or something, if I can just get it out of the way, then I can help this person. Well, that thing is probably the thing. That thing is the problem. And you have to figure out what that problem is, conceptualize it, and have a treatment approach to that problem. At the very least, because then after that problem is diminished, you can start working on the thing that they came into therapy for. But sometimes that thing is the thing, and the other thing, like depression, the original presenting problem, is a symptom of the thing, say borderline personality or something like that. So there's this practical urge and the way people talk about, and I've seen it, I've seen trainings or TikTok videos or whatever of people talking about, in fact, it's often advertised this way. A lot of life coaches will lie to the public, either knowingly or unknowingly, and say that coaching is practical and therapy is not practical, and coaching is short-term and therapy takes forever. It's like, no, therapy can take forever, but we have, as a field, psychotherapy, we have researched and developed for decades brief therapies, very short-term therapies. These life coaches that think they've invented something is just ridiculous. We have it all over the spectrum. Short-term therapies, medium-term, long-term. You can even do psychodynamic therapy, which is more associated with long-term. There are brief models, brief psychodynamic therapy. So this notion that CBT is practical, and usually what that means is the therapist basically, kind of like Dr. Phil, just berates or tries to convince the client to do X, Y, and Z, and then terminates with the client. And what I think happens a lot of the time is the client ends up terminating because they feel like they've completed therapy by a certain point, because the therapist seems to be saying, there's nothing more I can do. You just have to follow these things and then you should be okay. And the client is like, oh, okay. Some of you might have even been through this. And you go home and things haven't really changed, and you end up just concluding that there's something wrong with you, instead of the therapist figuring out how to specifically help you and look beyond the practical problem. So that can happen. Or the client will just quietly terminate with the therapist without verbally or communicating to the therapist that the client actually hates the therapist or feels judged, and the client will seek another therapist. Meanwhile, that practical therapist thinks they cured that person because that person said, I'm all good, thanks. I think I'm done with therapy, and this will be our last meeting, or I don't need the next meeting, and so thanks a lot. And then they walk out the door and they just roll their eyes. Meanwhile, this practical therapist is walking around thinking, and it's not all CBT people. But yeah, so I could. The other thing, to speak specifically to you, Sarah, in Illinois, about Carl Rogers and its practicality, the research shows, this is science, empirical evidence, that when you actually understand Carl Rogers' breadth of approach and mindset and philosophy and paradigm shift, it's hard. The phenomenological mindset is, we're talking Heidegger and all this, it's insane. But when you understand it well enough and you provide that therapy, then the kinds of practical outcomes that you're looking for, like, hey, I'm depressed, or hey, I don't know, I don't like my financial situation. The Carl Rogers approach is not just listening. This is another thing that I would go over with my students a lot, is they would, inevitably 6 months into their internship, they would say, I don't know, I feel like with this one client, I'm just listening. Now, sometimes you're spinning your wheels and sometimes you're resisting yourself as a therapist. You're just like avoiding something. So there's an investigation there. But listening is one of the most powerful, effective, curative agents that humans have ever evolved. That's an interesting sentence. We can cure so many things by, quote unquote, just listening. And again, it's not just listening. You're not just like zoning out. There is phenomenology. You're asking questions along those lines. You're present. You're authentic. You're with the person. Carl Rogers, his style was his style of doing that kind of listening, but my style of doing Carl Rogers type of phenomenological listening is I talk probably more than Carl Rogers would. I don't talk more than the client. Usually that means something has gone awry with me. But, I'm probably talking like 3% of the time, 5% of the time, but Carl Rogers would say very few words, just these little prompts to encourage the person to keep going. But I'm more active and also I'm integrating all these other theories. Anyway, I'm not saying better Rogers by any means, but it's just different styles. Every therapist is different. So Carl Rogers' authentic and phenomenological listening is a practical therapy. Now, as I've been saying, the breadth of problems that come into therapy, I think it's a good idea to understand all the theories because, maybe with one client, Carl Rogers is all you need. Another, CBT is all you need. Now, also, I will say that CBT can be very quote-unquote practical in that when it comes to exposure and PTSD and OCD and phobias and generalized anxiety, behaviorism is very practical. There's a script to it, and I will absolutely stand behind that. And I've talked about that for a long time. Anyway, let's take a break. Get back, more emails. All right, we're back from the break. So this next email is from patron Marina from God knows where. She says, "Dearest S. Dr. Kirk." So dearest S. So not only am I dearest, but I'm the est of the dear. Anyway. I don't know if that was a typo, but I appreciate it. I'm flattered. "You are my best friend, with your permission, and I am so grateful that you exist and make the world and my life a better place." Just chiming in. Well, that's really nice. I know. Yeah, parasocial best friend. It's reciprocal. Going on. "Could you please do a lecture, yammer, or dare I say deep dive on how to build a therapeutic relationship? I am a therapist and soon to be a psychologist in a couple months, but learned most of everything from you for my professional and personal life." End of email. Wow. It kind of sounds like you have a similar development career-wise as I did, in that I was, for a while, a master's level therapist, and then I went back and got another master's and a doctorate to become a psychologist. So it kind of sounds that way. There's a lot of wasted energy and money and time to do it that way. It's not, I don't recommend anybody do it that way, but it can be enhancing and just the sheer amount of education and internships and time that you spend in academia. And anyway, so yeah, I picked this email because it's kind of in line with what I've been talking about so far. So the therapeutic relationship. And this kind of applies for non-clinicians out there to every relationship in a sense. At least there's a practical, not practical, there's a non-therapist application of all these ideas, absolutely. So to build a relationship, all right, so we want to look at evidence, right? We want to look at science, and there's a lot of science on how to build a relationship. There's also a lot of science that demonstrates that the relationship between therapist and client, as I'm about to define it, is a lot more causal of change, positive change in clients than your theory of change. In other words, if you take a bunch of therapists, regardless of the particular theory that they adhere to, and you have 50 therapists that aren't very good at developing relationships and 50 therapists who are, and then you just kind of randomize the theories that they all adhere to, and they could be very narrow, they could be integrated like me, whatever. The variance in the difference between the outcomes of those two groups, for the 50 that are not good at developing relationships, for those clients, compared to the 50 who are good at developing a relationship, there's a sharp, line on the graph that shows a difference between those two. It's hard to describe. It's been a while since I've taken statistics, and it's also been a while since I've looked specifically at this area of research, of which there's a lot. So there's a lot of importance. In fact, one could argue that in graduate school you should spend 3 to 5 times more time in graduate school talking and learning and doing relationship building with your client as opposed to theory. You should be spending so much time learning how to build. Now, one of the things that I will say is that that's a weird way to start a sentence. It's like, well, I'm saying a lot of things in this episode, Kirk. Like, why did you start it that way? Anyway, maybe one thing I want to point out is that a lot of what I'm about to go over in terms of how to build a relationship that is demonstrated by empirical science is very closely, if not firmly, within particular theories. So you could learn the theory and it will absolutely help with the relationship. Humanistic psychotherapy is a big one, and also psychodynamic, relational psychodynamic work, or interpersonal, intersubjective work, which is also kind of psychodynamic, is another part of it. By the way, my following lecture yammer, not deep dive. I would love to do a deep dive. I'll put it on the list, but I got a lot of other. I want to do paranoid personality disorder. I want to do the Menendez brothers with Berto. I want to do psychopathy. I've never done a deep dive on antisocial or psychopaths or sociopathy. Anyway, but what I'm pulling a lot of what I'm about to say from is a book by John Norcross, which I was talking about earlier, called Psychotherapy Relationships That Work. I took the dust sleeve off because I actually don't like dust sleeves, so I forget what it actually looks like. But anyway, I don't know if you could see that, but psychotherapy. Yeah. It's a very academic book. It's filled with it's just one long literature review, and it's dry, but it's convincing. Okay. So, and while I'm on the subject of books, I actually pulled a lot of books. I don't know if you can tell, but there's certain shelves behind me that are a little empty right now because my main books are usually right behind me. But I have Phil Cushman's book here, Constructing the Self, Constructing America. That's this book, if we're talking about psychotherapy theories, is transformational. It's called Integrative Multi-Theoretical Psychotherapy by Jeff Brooks Harris. So if you read this book as a therapist, you will not have a super firm understanding, because it's one of those big 8 kinds of books, right? It goes over all the big areas. In fact, let's, just as a curiosity, it goes over cognitive therapy, behavioral therapy, experiential humanistic, biopsychosocial, psychodynamic, systemic constructivist, and multicultural feminist. So is that 8? I think it is, yeah. So what this book does is it's a very brief overview of that, as any book along these lines would be. But what it does is it gets practical. In every chapter, it says, okay, now that you have a brief overview and presumably you've learned about this theory in other classes or other areas, what does it look like? What's the preferred outcome? When I read this book, I don't know, 20 years ago-ish, when did it come out? It came out in, or at least this version, well, it came out 30 years ago. Man, I could have used this book in the beginning, but I modeled the way I taught and also the assignments that I would give my students based to some extent on this book of, okay, what is the assessment? What's the problem? And how does that dictate treatment and intervention? And what is your preferred outcome as you plan this intervention? And the intervention can be, quote unquote, just listening. Interventions don't necessarily mean that you have to actively tinker with something. And then how are you going to check to see if the preferred outcome happened or not, in what way, so that you can iterate on your treatment model? Now, for some of you, this might sound too rigid or scientific, and it can be used that way, but it can absolutely be used in a Rogerian humanistic sense as well. And there's a lot of therapists out there, and I've complained about this before, who don't even have a grasp on what they're doing. They adhere to a theory, they feel like they understand it well enough, but if you ask them, why does it work, they don't have an answer. It's like, well, it works because, and I get it. Most of the problem is because therapists are not taught, because they're taught by people who also can't answer that question. Anyway, so this book attempts to kind of answer those questions. Carl Rogers on Becoming a Person, of course, is a classic. Systems Theory in Action by Shelley Smith Acuna. Psychodynamic Diagnosis by Nancy McWilliams. You have a book on projective identification and psychotherapeutic technique by Ogden. Very important book. This is a very important book for psychodynamic work and interpersonal and intersubjective. It's called Interpersonal Process and Therapy by Tabor and McClure. Of course, you got to have Yalom, The Gift of Therapy. This is good for Bohemian and kind of systems. It's called Extraordinary Relationships by Roberta Gilbert. And this is also an important relationship for humanistic, psychodynamic kinds of work. It's called Between Therapist and Client by Michael Kahn. One time I was signing up for trainings at a convention, and I saw that Michael Kahn was teaching a class. And I was like, oh, I love that book. I'm going to go to his class. I go to the class, and about, an hour into the class, I realize, oh, this is a different Michael Kahn. Kirk Honda. Anyway. This book on social construction by Gergen. This book on schema therapy by Jung. It's just called Schema Therapy. You have this book by Wallen. It's one of my favorite, called Attachment and Psychotherapy. Of course, all the John Bowlby books, Attachment, Loss, Grief. This book by Ronald Takaki called A Different Mirror. A fellow Japanese-American brother wrote a very important work on looking at history through an objective lens rather than filtered through the white lens, if you will. Anyway, this book by Farber called Self-Disclosure and Psychotherapy, again, goes over the effectiveness of it and the importance of it, and also how to not make it about you. Anyway. And this has to do with alliance, negotiating therapeutic alliance by Safran and Muran. So a lot of these books are the kind of foundational books. They're not like this book by Smith Acuna, The Systems Theory in Action. It is a great book, but it's, I believe, a therapist professor who is integrating a lot of theory and trying to boil it down so it's understandable to people, which I appreciate. But some of these books, like the John Norcross book or the Farber book, these are the primary researchers in that area. So, like John Bowlby, this kind of thing. The Schema Therapy book by Jung. I can't remember his first name. You think it's Jung, right? But it's actually it's Jung, like young and old. Jeffrey Young. Anyway, so let's talk about how to build a relationship. So first off, let's, again, talk about Rogers and humanistic psychotherapy in general. But if we're talking about Rogers in particular, because Rogers was one of the only humanistic theorists who actually systematically described and researched what it was that he did. There was a lot of humanistic practices back in the 70s and maybe back in the 50s as well, where it was basically just whatever the therapist wanted to do. It was kind of a chaotic time in our country, and also in the field of psychotherapy. There was a rebellion, and there was a a shirking of authority. And so there was a lot of just therapists who just wanted to behave intuitively and do whatever they wanted to. Fritz Perls being one of them. But anyway, so Carl Rogers, you want to understand positive regard, congruence, authenticity, empathy, this kind of thing. And the tagline for these concepts are too simplistic. Positive regard. Oh, okay. So unconditional positive regard. Okay. So, but it's complicated because you don't approve of everything that a client does. Also, sometimes you hate your clients or you dislike them, or you're uncomfortable. So you're supposed to force yourself to have positive regard about a client talking about abusing another person. No, it's way more complicated than that. It has to do with not only what you communicate, but more fundamentally how you think. Strength-based, love, giving people benefit of the doubt, not reacting in the typical human way out of defenses and that sort of thing. So it's really complicated, but that obviously helps a relationship, right? Congruence, meaning that you don't have crazy-making communication. Again, that's complicated. Authenticity, that you're a human being, you're not just this robot doing a thing. So just the whole topic of Rogers there is important. Then we have this thing called the working alliance, which I hope is talked about in graduate school sufficiently. But in all forms of therapy, for all problems, even in medicine, even if a plumber shows up to your house, these three elements of work. Now, a lot of times working alliance is just, if I ask students, what's working alliance? They'll say oh, well, you have an alliance between client therapists. No, this is a systematic concept of three elements, three components. You have goals, task, and bond. So the bond is the attachment and the goodwill and the familiarity and having the client believe that the therapist is on their side, that the therapist is safe, and also for the therapist to feel safe enough to help this client. So that's the bond, and it can be intense, or it could just, if you have some clients come in for one session, and you're not going to have a tremendous bond, before you start providing treatment, but enough of a bond given the context. You know what I mean? Anyway, but the other two elements, components of working alliance or therapeutic alliance, or just the alliance as sometimes it's referred to, are goals and tasks. So you have to collaboratively establish, the two of you, therapist and client, or therapist and family or couple, what the goals are. And even if you're a floppy, self-esteemy, intuitive therapist, it is critical that you have, at least in your style, a conversation about goals. Sometimes floppy humanistic therapists like myself will say, I don't like to follow those kinds of rigid treatment plans, because sometimes goals is interpreted as the way that CBT people talk, which is also valid, where it's you want to go from 5 negative intrusive thoughts a day to 4. And for the average humanistic or less rigid, less CBT-oriented therapist, they're just well, that's not really how I operate. I'm more holistic. And that's okay, fine. But you still need some kind of indicator of change, of things getting better. And it could be as amorphous as a client just telling you that they feel better or that they don't need therapy anymore, or they feel like they've explored sufficiently their life or something, they've developed whatever it is, there should be something there. Okay, so that's number one. And clients are looking for that. People don't come to therapy to just kind of sit there and just sort of float in the ether. Whether they're concrete about a goal or they're more floppy themselves, they definitely are coming to therapy for a reason. And sometimes clients don't know why they're there, and that needs to be clarified. Some people are in therapy because they shouldn't be, but some people are in therapy and they just don't have the words because they're not clinicians. Anyway, so you can have 6 months of sessions just trying to triangulate the goal. Okay, so goals. Now, most of the time, clients come in with pretty concrete stated goals, like a couple doesn't want to fight as often, that kind of stuff. Then from the goals, we establish collaboratively the tasks. Now, often this is the one part of the component of the alliance that largely comes from the therapist, because how would a client know what to do in therapy to help achieve that goal? We should be supplying that, but the client is a part of the conversation, and they might not want to do X, Y, and Z. They might want to do A, B, and C. So you have to be ready to present well what it will look like. Again, it can be very concrete, like in the case of exposure therapy, or it could be very floppy, like here's what it'll look like. You'll come in, we'll have a little chit chat, and then I'll say, okay, what do you want to talk about? And you'll just talk about whatever you want to talk about, because that's the task. That's the function. That's what I'm going to be doing. That's what we're going to be doing together in therapy to reach the goals that we established. Now, sometimes clients will have a goal, and as a therapist, we have to modify it, right? If a client came in to me and said, I want my wife to obey me more. Yeah, I was like, well, what's more fundamental that there's a chance that what's more fundamental is trust and a bond and lower conflict and that kind of stuff. You know what I'm saying? So there's a collaboration there. But then once you have the goals, then you have to be able to, as a therapist, and use this book. Where'd it go? If you want to get some ideas about what to say, like, let me just give an example here. So in I just opened a cognitive therapy. So the kinds of things that I'm sort of flipping through here. So there's a bunch of different strategies, which are umbrella intervention categories, you know. So one thing that cognitive therapists do is identify thoughts, okay? So if you know anything about cognitive therapy, you know that identifying thoughts, automatic thoughts, or narratives, this kind of thing, is critical in cognitive therapy. So if someone came in and you believe that cognitive therapy would help with them, then you would identify the goal, you know, say depression, and then you say the task that we're going to do that I recommend based on research and my experience and my training is that we do cognitive therapy, and specifically what that will mean is that we'll be identifying your thoughts, your automatic thoughts. And here's an example of what that can look like. Okay, so, and by the way, I'm kind of curious about actually just going through some of the more, because, you know, cognitive therapy, like I said, is powerful, but it's fairly easy to get. So let's look at psychodynamic, page 277, and look at the categories of interventions that the author has laid out. Okay, so there's 16. Okay, so these are all psychodynamic interpersonal strategies. So it's kind of a contemporary relational, intersubjective, interpersonal, psychodynamic, psychoanalysis, object relations, you know, it could be all kind of related. So you have listening to narratives, and I could go into details, and it does in this book, as to why that is actually within the theory of, and that might to some of you sound like narrative therapy, and it can be, but listening to narratives is solidly psychodynamic. Encouraging free association, for some of you might think, oh, that's kind of like mumbo-jumbo Freudian stuff, and it can be, but a more regular version of free association is just allowing clients to meander through their narrative or through whatever they talk about, you know what I mean? Because that can reveal things. Identifying relationship themes in their personal life, right? You know that if you listen to the podcast or watch my videos, you know I'm frequently doing that. Making interpersonal interpretations, it's very important, is, you know, if you watch my reaction videos and to some extent listen to the podcast, well, maybe in a robust way with all that stuff, you will hear me interpreting interpersonal relation. You know, someone will email in, or I'll watch a reality TV show, and I'll say, I think what's happening there, but I can't know because I'm not in their head. And even if I was, I would not be aware of everything that's happening. So it's an interpretation, a way of conceptualizing why people act that way in relationships and what the flow chart is. Honoring resistance, which I'll get into in a little bit later. Exploring childhood experiences. Of course, that's very psychedelic. It's among all the 8 umbrella theories, childhood experiences is only in one of the umbrellas, and that is psychodynamic thinking. I mean, you could argue, well, no, I'll go down that road. Identifying attachment styles. So this is kind of new because for many decades, attachment theory was not considered to be a psychodynamic related theory, but it has become that because it does fit very well. And, it has to do with childhood experiences and development of personality and defenses. Anyway, observing the therapeutic relationship. Observing as a therapist, you're observing the relationship between client and therapist, very important for psychodynamic therapy. Attending to subjective responses, so client having responses that are subjective and then you attend to them. It's complicated. Resolving conflicts in the therapeutic relationship, which I'll get to in a second. Modifying relational interactions, so not only in session but outside of session, so that their relationships are more functional and more fulfilling to more meet their needs. Interpreting dreams. Not every psychodynamic therapist does this. I do. There's a lot of bullshit and pseudoscience around this, and if you want to learn more about my style of interpreting dreams, you can listen to my episodes on that. I have a fairly specific way of approaching it that I think other people have as well, but it's I think a little particular to me. Adapt, meaning that I don't interpret someone's dreams. Someone doesn't tell me like I was flying. It's like, oh, that means that. That's all bullshit. Science has demonstrated that. It's ridiculous. What I do is ask a bunch of questions, and if we run into a roadblock, then I might tentatively suggest, well, like, I know we talked last week about this thing. Do you think that might have something to do with it? Because I don't want to insert meaning into the scenario. Anyway, and I have to gauge whether the client is too susceptible to suggestion, and therefore I shouldn't even do that, Anyway, adapting to interpersonal losses or disputes, kind of self-explanatory. Encouraging new relationships outside of the therapy, and then learning from termination. Yeah, so those are common maybe to all the different therapies. But you get the idea that when you read about psychodynamic therapy in another book, they might not get that specific. That was very specific. Listening to narratives, interpreting relational experiences, helping them with their relationships. So okay. So working alliance. So Rogers, positive regard. So this is all relationship building. Congruence, authenticity, working alliance, which is goals, task, and bond. And if you're a student or a therapist that's practicing, you should be able to, off the top of your head, rattle off the quality and specifics about the working therapeutic alliance of all your clients. You should be able to and if you can't right now, that's fine. You were not supervised or mentored or taught well enough, which is totally fine. But you need to be able to quickly rattle off, oh yeah, with this client, without going to your notes, you should just be able to think in your head, what's the quality of the bond? What are our collaborative established goals that we might mention in every session? And what tasks have I proposed that the client has collaboratively understood what I mean by the task? And maybe I have to demonstrate it. And the client has said, yes, I want to do that, or I'm willing to give it a try. You should be able to do that with all your clients. Okay. And of course, it makes sense. And again, this has to do with medicine as well, which is often overlooked, right? Empathy is a big thing, and it's complicated. And I did a whole deep dive on empathy. In this context, we're talking about not necessarily viscerally feeling, I had those different types of empathy. We're mainly talking about having empathy, demonstrating empathy, having, what were my different types? I won't go into it right now. And also the understanding types of empathy. Listen to the deep dive. Also, according to this, so this John Norcross book is called Psychotherapy Relationships That Work. It is he's the editor, so he's getting the lead researchers in all of these areas who have spent their whole lives reviewing and conducting research and thinking and So there is an entire chapter in this book on collaboration, which I've kind of already been over, about conceptualization, diagnosis, goals, tasking. Another chapter in this book has to do with having a solid approach to resistance, which is complicated. But another chapter in this book is feedback. So it's been shown that just asking for feedback from your clients, whether you listen or not, whether you incorporate the feedback or not, will improve outcomes to some extent. And if you listen and value and validate and then incorporate that into, whether it's, if they give you good feedback, you're like, oh, okay, I'll do more of that. Or if it's negative feedback, you change things, then the outcomes are even greater, right? So it's important. It's collaboration, it's valuing, it's taking the risk yourself as a therapist. And I'll tell you, in the beginning of my career, when I was tasked or had the impulse to get feedback from clients, I was terrified. Therapy is so amorphous. Young or novice therapists are walking around in a perpetual state of wondering, am I doing anything? Am I horrible at this? Because you spend all this time online or in graduate school hearing about all the greats and all the successes. Your professors talk about all these great achievements that they've made with clients. Meanwhile, you're getting clients, typically in the beginning of your career, who have the most compounding problems. Not only are they depressed, they're also anxious. They're suffering from poverty. Their community has violence in it. They are struggling at their work. There's political things afoot to minimize their pay or to take away their pension. There's just a lot. And it could be hard, if not impossible, to see noticeable gains in the short time that you have as a novice therapist or even with particular clients because they lose funding or they can't organize their lives enough to get to therapy or they don't have time for it. They're a single mother of 5 kids or, it's hard. So a lot of novice therapists are walking around just like, I don't want to ask, including me, I don't want to ask my clients about feedback because I'm fairly sure that they're going to say I'm a horrible therapist. Okay, so we have to get over that. And that's where mentorship comes in. Rupture repair, very important. Noticing ruptures, taking responsibility for them as a therapist, and having a very robust relational way of repairing. This is psychodynamic work. So, anyway, self-disclosure. I've heard professors say that self-disclosure is unethical. And one, that is just ridiculous. It's not the standard of care. It's not really what people are proposing. Plus, there's tons of research that demonstrates that effective self-disclosure is helpful to positive outcomes. And off the top of my head, the key components of effective self-disclosure, if I can remember, is that it should be as short as possible, which makes sense. It should be processed enough as the therapist, right? We don't want to self-disclose something that we're very activated by because it can scare the client and make the therapy about us. And also, we want to disclose something with a fairly reasonable conclusion that by self-disclosing this, it will help the client. I think those are the 3 components. So when you do it that way, evidence shows that there's improved outcomes across the board, regardless of what sort of client you're working with, regardless of what sort of therapy that you do, whether you're CBT or psychodynamic, self-disclosure helps. Another key component is countertransference management, which is a whole ball of wax. We're talking about tons of therapy and self-awareness, not only just about your own traumas and your own personality, your own attachment, your own biases, but also just like your cultural countertransference. So, and you notice that what I'm not saying is getting rid of your countertransference, because that is philosophically impossible. What we're talking about is management. So you acknowledge it and you manage it for the betterment of the client and yourself. Relational interpretations is another chapter in this book. I've already been over that. Stage of change, Very important. I drilled this into my supervisees, and it's common for graduates to have never been introduced to the concept of stage of change. It's not really a historical key element of psychotherapy instruction for whatever reason. I didn't come across the theory of stage of change until maybe like 10 or 15 years into my career. And there's different models, but to just explain it very briefly, is that clients come into our office, it's often assumed they're at the action phase, meaning that they know they have a problem and they're ready to do the legwork to work on things. But that is not the case. And some clients might be in the action phase for one problem, but not another. Okay. So we have to assess where they are in that process. So there's action. So the four different main categories is you have pre-awareness of you don't even know that you have a problem, and you might even be resistant to acknowledging that you have a problem. And people might say, hey, you have a problem with this, and the person's like, no, I don't. Okay. Or they just haven't been exposed to that. Okay, so that's pre-contemplation is what they call it. Then there's contemplation. I'm sort of mashing things together, but then there's contemplation, where you recognize you have a problem, but you're not ready to take action because it's overwhelming, or you don't have the energy, or you're not sure. Then, generally speaking, the next phase is action, where you acknowledge the problem and you're ready to go and you're putting in the effort. Not all the time, but enough of the time. Then there's a final phase of maintenance, meaning that after you've made the changes and things are improving, you have a maintenance approach to not falling backwards, that sort of thing. Okay. So as a therapist, it is critical that once we establish the collaborative goals, that we have a sense, if not directly asking about this sort of thing, about where they are in the stage of change. Because if they're at the action phase, then let's go. A lot of therapy is geared towards the action phase. But what if they're in the pre-contemplation? What if they're in the contemplation? What if they're not ready to take action? And the acknowledgement that there's a phase there is important. Just because someone knows there's a problem doesn't mean they're ready to actually take the leap and change, because it can be hard, there's an unknown and it takes energy and da-da-da. So gearing the therapy towards that. For example, with people who are pre-contemplative or pre-awareness of a problem, solution-focused and narrative therapy, postmodern therapy, collaborative therapies, in my opinion, and I think others, is helpful at that phase for reasons that I won't do because this is taking too long to talk about anyway. And the last thing to think about is attachment. Not only just attachment in general in terms of the bond, but also attachment theory and styles, your own and the client's, because the attachment, the relationship between the two of you. Anyway, so that is my mini lecture, mini yammer. Not a deep dive as you were hoping for, Marina, but definitely yammering talk about the relationship. And I feel like I've talked about it before, but maybe not to this extent. And I guess this whole episode was just geared towards therapists. So if you're not a therapist, let me know if this is helpful or not. I don't know. Or is it just a curiosity, like you're listening in on a class or something? So as a professor, I would, in all my classes, talk about these various things as they apply to the topic. And it takes a long time. You can learn this stuff. Oh, okay, positive regard. Okay, I'll try to remember that. No, it is a paradigm shift. Some of you who will watch me watch reality TV will notice this difference, that with the general audience of reality TV, they do not have positive regard for the cast. And I do. Now, part of that just has to do with the way I was raised. I was raised well and wasn't traumatized, and was shown a world in which humans are good and that I'm a good person because I'm being treated that way. And I just assume that everyone else is also good, unless they're a psychopath or a sadist or something, which they exist, but they're rare. So that's part of it. But also another part of it is my adherence to the full breadth of the paradigm shift that is Carl Rogers and all the things that he and his colleagues talked about. So it's not just something that you have a checklist for or a little reminder, like a post. Have positive regard. It's a whole different way of seeing the world that results in positive regard, results in empathy. It's not forcing positive regard into us, not forcing empathy. It just emerges because you are now a different person interpreting the world in a different way. That's the power of that kind of thing. Phenomenological listening is a similar thing. Anyway, one of the things that I will see in that as a piece of evidence of my trainees once they make that paradigm shift is they will stop saying I'm just listening. They will say, and I listened. It's a paradigm shift. They're like, and I listened the fuck out of that client. What I always tell my trainees is, when you're a client, what are you hoping for? That the therapist gives you some kind of skill or assigns homework? I'm going to take a guess and say that most of you are at least half looking for your therapist to quote unquote just listen, to really listen and care and be with you as you're telling your story. Even if you're off base or you're distorted or something, to have someone with you is a powerful thing, right? Anyway, so that does it for that episode in which I yammered about therapy stuff. And everyone out there, please take care of yourself because you deserve it. You really, really do.